Welcome to Aetcm, the emergency medicine channel. Today we are discussing about a geriatrics emergency case. So hyperglycemia and geriatrics. We'll see what type of case it is. Can we start?
It's a 61-year-old male from Kakanad who's a retired worker from NPTL came with complaints of generalized fatigue, nausea and loss of appetite for past 3 days. He was apparently normal 3 days ago, after which he developed generalized fatigue and he was not able to do his regular activities, and he found weakness just to walk in this house itself, and it was associated with loss of appetite. He had early satiety, no dysphagia, odynophagia, no loss of weight. He had no history of altered sensorium, vomiting, fever, chest pain, palpitation or breathing difficulty. He noticed his sugars were high, and he came here for further management. His past history is he is a known diabetic for past 25 years and systemic hypertension for the past 20 years and dyslipidemia for 18 years, and he has had a varicose vein surgery 20 years ago and left eye cataract surgery 2 years ago. He is on current medication he is on sitagliptin 100 mg in the morning, metformin 500 mg at night, and AC inhibitor 4 mg twice daily, and atorvastatin 10 mg at night. His personal history is normal bladder habits. He uses Ayurvedic medications to relieve his constipation, and he has reduced sleep and reduced appetite since 3 days.
So can you tell me the reasons for constipation at this age group?
Sir, it is the reduced intestinal motility.
In diabetic patients, intestinal motility is reduced. Either sometimes they can have reduced intestinal motility and constipation, sometimes because of autonomic dysfunction, more motility and diarrhea. So both are possible. So this patient has got constipation, and that may be due to diabetes. What are the other reasons for constipation?
Age also, sir.
Age is one reason. Then causes for constipation. It's a very important topic, especially in elderly individuals. What are the reasons? One is diabetic. You told. Age you already told.
Then
most common cause is what?
Reduced appetite.
Reduced water intake.
Water intake and reduced
water
appetite.
Intake is the most common cause, and fiber intake. Reduced water and fiber intake. Then he can have Parkinsonism. He can have Parkinsonism, reduced motility. He is on metformin, again that can produce decreased appetite and constipation. So many causes are there. In that, most important cause is always think that it is water deficiency. He is not taking water and fiber. It's the most important cause. Here, like you told, diabetes may be one of the reasons. Okay.
His water intake is around 1.5 liters per day.
It's very low. Okay.
And family history, all his brothers are diabetic and no other significant family history. Socioeconomic history, he's a retired helper from NPTL, and he lives with his wife and he has no children.
Okay.
And financially he has his pension.
Okay.
So to go on.
He's a diabetic patient.
He
come with very high blood sugar. He's on OHS, not on insulin.
Not on insulin.
Not on insulin. He has got early satiety.
Maybe
due to some infection or due to metformin itself. But he was on metformin so many days, so we will not consider that. We have to think about an infection. Okay.
On examination, he was moderately built and nourished. He was conscious, oriented to time, place and person. No pallor, icterus, cyanosis, clubbing, mild bilateral pitting pedal edema was there. Afebrile. There was hyperpigmentation of left lower limb with varicose vein scars present. MMSE was 28 on 30. Geriatric depression score was 3 on 15. BP on supine position it was 140/80, and in sitting position it was 140/80. Pulse rate was 82 per minute. All regular and odd peripheral pulses were felt. Saturation was 99% at room med. Central nervous system examination, speech and memory was normal. There was no cranial nerve deficit. Bulk and tone was normal. Power was 5/5 on all 4 limbs. Position sense were normal, but vibration sense were reduced in bilateral lower limb.
Why vibration sense is reduced?
Peripheral neuropathy can be a possibility.
One of the common presentation of peripheral neuropathy, that's a large fiber neuropathy, is loss of vibration sense. Okay.
No cerebellar or meningeal signs were present. In cardiovascular system examination, there was no JVP elevation. Apex beat was not visible. No heaves or thrills. Apex beat was present in the intercostal space, half-inch medial to mid-clavicular line, and first heart sound and second heart sound were heard normally with no murmurs. Respiratory system, nose and nasal cavity was normal. Trachea was in the appeared to be in the midline. Bilateral chest movements were symmetrical. No scars or sinuses. On palpations, trachea was confirmed to be in midline. Bilateral chest was movement was symmetrical, and all vocal parameters was normal, and all areas were resonant on percussion, and bilateral normal vesicular breath sounds with no added sounds were present. And oral cavity examination was normal.
What in oral cavity you look for in this type of patients?
Any dryness of mouth.
Dryness of mouth can be there because diabetes, old age, all these things. Then
any.
He's on calcium channel blocker.
No, AC inhibitor.
AC inhibitor. Okay.
And any
to look for any dental infections.
Dental infections are dental and gum infections are very common in diabetic patients. So
and abscess.
okay, abscesses. So that should be ruled because he is having fever. We are not able to find a focus. Then examine the oral cavity properly because high blood sugar is commonly associated with gum infections. Okay.
And on upper abdominal examination, shape was normal, umbilicus was inverted, and no scars and sinuses were present. No hepatomegaly, splenomegaly, and abdomen was resonant and bowel sounds were heard normally. Geriatric examination, nails were trimmed properly. There were no bed sores present, and no other significant findings.
Okay.
So to summarize,
abdomen, hernial orifices.
That is very important.
Empty.
Okay.
So to summarize the history, and a 61-year-old male from Kakinad who is a retired NPTEL worker came with complaints of generalized fatigue, loss of appetite for past 3 days with a background history of type 2 diabetes, hypertension and dyslipidemia with history of constipation, and on significant examination only bilateral pitting pedal edema with hyperpigmentation and reduced vibration sense was present.
Okay. Is there anything else?
Loss of appetite, rule out any icterus and high colored urine.
Icterus should be ruled out.
There was no icterus and no high colored urine or
The age malignancy.
Very common.
there is no loss of weight, sir.
Loss of weight is not there, but loss of appetite.
Loss of
It's in the
appetite.
initial stages. You can just.
Okay. So how do you proceed with this case?
So first we go on to investigation. To rule out any infection, complete blood count.
Okay.
To look for hemoglobin levels also, and inflammatory marker CRP if any elevation is there.
Okay.
Then to look for the kidney status, renal function test because he's a chronic diabetic
The
and
most important
hypertension.
investigation in this type of patient is
Fasting,
urine.
urine routine.
Because the elderly individual, prostatomegaly can be there, then diabetes is there. So urine routine is the best investigation should be asked. But I don't know whether he has got UTI or not, but we'll check.
And urine routine to look for any protein loss or any ketone pustles or ketone present, and renal function test, liver function test.
Okay. What is the blood sugar on arrival?
On arrival, it was 360.
Okay. So once you see a patient who is having high blood sugar, the next most important investigation is what in emergency room? Very high blood sugar. Ketone bodies. Okay, you can ask either urine ketone bodies, blood ketone bodies. Blood ketone bodies are better than urine ketone bodies. Both are not available immediately. You can ask for an ABG. You can see whether acidosis is there or not. Okay. This patient, does he have an...
He didn't have
so he's having a hyperglycemic episode. What are the reasons for hyperglycemic episodes like this?
Poor drug compliance.
He is having 10 years of diabetic history. He is on the same type of drug. A good knowledgeable person. Drug compliance may not happen. What will happen?
He might have missed.
Most important is secondary OHA failure. Okay. Primary OHA failure means you start immediately, that shows no response. This is after 10 years. This is a time to fail. Okay. 10 years of long-term diabetes. He was on some drug, now it is not acting. So it will be secondary OHA failure. On top of that, he might have developed some infection also. We don't know. So how do you know that this sugar is controlled or not controlled? What is the HbA1c level?
His HbA1c level was 8.2.
So that is not getting controlled. There is no good control. So what will be your control according to geriatric patient protocol?
7.
Normal person it is 7. Okay, like a young adult it is 7. Pregnant lady it is 6.5. An elderly individual like this, we don't want to have that much tight control because they may go to hyperglycemia. So we may target around 7.5. That is a standard recommendation. 7.5 is required, but he has got 8.5.
8.5.
Okay, so that is one important thing. Now you have to rule out infection. Any infections are there? You don't find any infection here, but there may be some occult infection. We have to find out what is that. It can be some oral cavity lesions, sinusitis, so many things can happen. But most of the time, why the patient is not having symptoms? See, normally somebody is having oral cavity infection, sinusitis, anything, they will have symptoms. Why diabetic patient will not have symptoms? Autonomic failure, they don't feel the pain, and inflammatory response is reduced. Both are there. Okay, that's why long-term that gum infections can be there in diabetic patient. They will be unnoticed. Okay, so you should have a thorough checkup for all these things. How do you control this sugar? This patient was on metformin, sitagliptin. Okay, are you satisfied with that?
No. So
How do you?
we can immediate control can be taken with insulin.
Okay. So when you are thinking about this type of patients, last 10 years he was on OHS. Now it is failed. You should not depend on that drug. You have to start on insulin. How do you start insulin in this patient?
According to his fasting and postprandial charting and HbA1c levels.
But you are not that experienced to start with his charts. So as a junior doctor, how do you initiate insulin? See, suppose it's a very experienced physician, he can tell some 15 we'll start, but you not have that confidence. So how do you start?
Based on
this patient is admitted in your hospital. You are secured in a good place.
So short-acting insulin will start with the basic fasting and with the basic GRBS charting. And according to the GRBS, we can give the short-acting insulin and monitor the thrice daily. And according to the pattern, we can set a fixed dose on discharge.
Okay, so from your experience, this patient's blood sugar is 300 something.
383.
83. He is on metformin with the sitagliptin. You want to stop the drug?
Yes, sir.
If you stop it, sugar will shoot very highly. So better not to stop if there is no contraindication. This patient is having a problem, like he is having anorexia. So I don't continue metformin because metformin can produce anorexia. Unless until there is a reason, we should not stop the drug. But since we are seeing a anorexia in this patient, I will stop metformin. I want to start him on insulin. How much insulin you can give for this patient? Is this patient creatinine normal?
Creatinine was normal.
Creatinine is normal. So there is no problem in excretion of the insulin. So you can start, suppose this patient's blood sugar is 300. I may start 5 units 3 times. Okay. Just imagine we are starting 5 units today, morning, afternoon and evening, because this insulin acts only for 6 hours. You cannot start long acting insulin in any patient who is admitted in emergency room. So now I am starting 15 units per day. When will you check the blood sugar? Before food or after food?
Before food.
Only before food.
Before food.
See, we are seeing the response of insulin. So ideally, when you give insulin, after 2 hours of every feeding, you have to see the blood sugar level. Okay. So after every, you give 5 units insulin, ask the patient to take food after half an hour, take the blood sugar after 2 hours. So you'll get a charting of blood sugar, thorough charting of that day. Okay. Suppose the sugar is not coming down with your 5 units TID, next day you can double the dose, 10 units TID. Okay. You have a control, in a controlled manner you are increasing, not suddenly you are giving 15 units TID. That time, sometimes patient can go to hypoglycemia. So next day you increase to 10 units TID. Again you are checking the blood sugar. Finally, you fixed a unit. You know that these sugars are controlled. Okay, it is something like 15, 15, 15. You are fixed the unit. And what is the target blood sugar in a patient who is admitted to hospital? target. You need to get a target.
140 to 180.
140 to 180 is a reasonable good target. Okay, so I fixed 15 units TID for this patient. That is short acting insulin, regular insulin. How do you identify regular insulin in a normal setup?
Right.
Pure water color or milk color?
Milk color.
Milk color is long acting insulin. It contains long acting. Water color is short acting insulin. Okay, so short acting insulin 3 times daily you are given 15, 15, 15, that is 45 units. Now this patient is ready for discharge. How do you switch to long acting insulin? So 45 units he is taking. You cannot give 3 times. The patient want to take 1 time or 2 times. That is comfortable for him. How do you do?
30% in the morning and 70%
So 45 units are there for this patient. If the total amount is more than 40 units, better to switch to 2 times, because one syringe contains only 40 units. You cannot give more than that. Again, you will have to take. So better to switch 2 times. So 45 units he is taking short acting. We may require only 2/3 of the short acting as a long acting. I am switching to long acting insulin. So 45 units he is taking. I require only 30 units when he go home. Okay, so 30 units I have to give. How do you give a short long acting insulin?
Two-third of the dose.
2/3.
So if it is again less than 40 units, you can give single time. Okay, so I can give 30 units long acting insulin with a mix of, it's a mix of short and long acting insulin. That will be given in the morning. When I give 30 units of mix acting insulin, that means it will be something like 30-70, 25-70. In that 30% will be short acting, 70% will be long acting. So when I give 30 units in the morning, how much will be short acting? 10 units will be short acting. That 10 units will act in the morning hours. Rest of the thing will act for next 12 hours. Then you see, then you ask the patient to come for a review after 2 weeks. Okay, what will you see? You have covered the morning dose. Night we don't know what is happening. So you have to ask for a morning blood sugar. Okay, what all things can happen to morning blood sugar?
It can go
If the sugar is not controlled,
it can
be high. If the sugar is very low, patient go to hypoglycemia. Morning again he can have hyperglycemia. Both are possible. So we should be very careful in elderly individual adjusting the night dose of the insulin. If you are getting a hyperglycemia in the morning, suppose you do all these things. Next time when he come, his blood sugar is again morning it is 300. What do you advise? Morning it is again 300. What will you advise?
night dose should be all.
Night dose we are not giving.
So
Suppose you are giving a night dose and 300 mg sugar is there in the morning. 8 a.m. the sugars are 300. What will you do?
increase the night dose.
There are two possibilities. When I give a night dose of insulin, either it is inadequate and you get a hyperglycemia in the morning, or overdose, you give more dose. Okay, instead of 10 units, patient has taken 20 units. What happens? Around 3 o'clock, he will go to hypoglycemia. What is the normal response of hypoglycemia? What is counter-regulatory hormones?
Increase it.
Counter-regulatory hormones. What is counter-regulatory hormones? Cortisol and glucagons. Okay, they try to increase the blood sugar. So post-hypoglycemia, hyperglycemia can possible, or hyperglycemia itself is possible. So how do you detect that? How do you know that it is post-hypoglycemic hyperglycemia or actual hyperglycemia? In that case, if the morning sugar is not getting controlled with your night sugar, ask the patient to take a 3 a.m. blood sugar value. If suppose that is showing very high, then it is actual hyperglycemia. If that is very low, then it is hypoglycemia, induced hyperglycemia. So when you are starting insulin in elderly, you should be very careful. Okay, what are the complications of insulin? We are starting a insulin for this patient now. Hypoglycemia, you should be very careful. You should advise the patient how to take insulin, what time you should take diet. All these things are very important. Then fat necrosis. Wherever you are injecting continuously on the same place, there will be dip there because of the fat necrosis and fat loss. Then it can produce some amount of fluid and water retention. Water retention is possible in insulin. Okay, then you are stopping metformin now. You are starting him on insulin. What will be the immediate problem? He'll have more appetite. So he'll start taking more food. Okay, that's one of the complication of insulin, but it is not a complication. It's an action. Okay, you are stopping one drug which produces anorexia. You are starting insulin. So you should be very careful. Okay. Anything else you want to rule out in this patient? This patient has got a anorexia for some days. You are not able to find out any reason.
You have to check for the vision.
Vision should be checked. Why you want to check the vision?
To rule out diabetic retinopathy.
Okay, vision is not related to diabetic retinopathy. Vision is related to your lens. Will you check the lens now? Power of the glass. When a patient comes with high blood sugar, will you send the patient for examination of the power? Yes or no?
Yes.
You are not supposed to send because of high blood sugar the lens properties are changed. So if you send now, that will give a false reading, and once the sugars are controlled, this will change. Okay, so unnecessarily you will be asking the patient to change his specs. So never do a power checking during the hyperglycemia episode. But what you told is a different issue. You told about retinopathy checkup. Okay, retinopathy checkup can be done. How do you grade retinopathy?
Grade.
There are two important grades. What are the two? Non-proliferative and proliferative. Non-proliferative means proliferation of blood vessel is not there. Other one, proliferation of blood vessel is there. What happens if there is proliferation? Neovascularization. That means lot of blood vessels will be formed there. What happens?
There will be cotton wool spots.
Hemorrhages are very important. So they can bleed into the retina. Sometimes retinal detachment can happen. So any patient who is having uncontrolled blood sugar like this, HbA1c 8.5, it always send for a retinopathy checkup. Okay, what is his age?
61.
So what are the other target organ damages you will assess in this patient? You have asked for a creatinine, that is very important. You asked for a retinopathy. How do you assess kidney? Creatinine is normal here. What else?
Ultrasound.
Ultrasound will not help you.
Urine protein.
Urine microalbumin. Urine microalbumin is the most important test to be done in this patient, so that should be done. Then heart. How do you?
Echo and.
Echo. What you will get in diabetic patients? You get diastolic dysfunction. That's all. You will not get any other problem. What else you can ask in cardiology? You have to ask for a TMT, treadmill test. So these are the important tests you should follow up in a patient who is having diabetes. Okay, sir. Anything else? Any other part you want to highlight? Anesthesia.
Anesthesia. Suppose the patient is going for a respiratory depression. In case you want to ventilate.
Or any surgery, sir, or drugs.
So it starts from the airway assessment. See, as the age goes, they may be having artificial denture or loosed or the complete denture, removable or fixed, we have to keep it. And is there any difficulty when you are doing a laryngoscopy, whether we can able to do mobility of the neck? So we used to keep the patient position the neutral, sniffing the morning air position. So that should be maneuvered only by the movement in the cervical joint, vertebral joints. So because of the age-related bone changes and all, there may not be any proper mobility available. Then regarding the lung functions, so during the ventilation, see all the research in the body, not only lung, everywhere the research will be reduced. But in the 60 years of age, it may not be that much. Okay, above 70, like that it will be there. So we have to come, and in addition, we have to take history about smoking or COPD. So far, whether he has been there. So accordingly, we have to manage the ventilatory aspect also. Regarding the drugs, see the conscious patient now he is suddenly deteriorating. Level of consciousness is deteriorating. So as far as the ventilatory support is concerned within endotracheal tube, first we have to completely knock down his consciousness, for which we use the induction agents. These induction agents alone it may not be sufficient, because you are doing the procedure of putting the laryngoscope, manipulating and passing a tube, all will cause sympathetic overlay. Okay, then suddenly the patient will go for increase the pulse rate and blood pressure. So in order to avoid that, we have to keep him with adequate analgesia. So these people, aged people, are very sensitive for all sedative drugs, especially morphine, pethidine, all this. So the dosage what we are using, we should be titrated dose according to the individual need. Well dilute, give smaller dose, then again repeat after some time, seeing the response. So in induction, we will be using the quickest onset drugs like etomidate or ketamine or other propofol, all these things. So here we have to select an agent which will cause least changes in the hemodynamic aspects, neither produce hypertension or hypotension or this thing, because these people suddenly going for hypotension, they may not be having the reserve mechanism, because autonomic imbalance also is there. And then it should be followed by the ideal agent. Maybe if the BP is normal or a little high also, you can go for etomidate. The BP is on the borderline or it is on the lower side, then we have to avoid the propofol. Ketamine is also another choice. Then the muscle action, quickest onset and shortest duration acting drugs. Yeah, these are all the things we have to keep in mind. And the ventilator strategies are no undue airway pressures. So we have to between 25 to 30 centimeters of water pressure. And once the patient is paralyzed and intubated, we can go for the ventilator strategies. The rate of the thing, depending upon the status of the respiratory system, this can be done with it. Yeah.
Okay, sir.
Very good, sir.
Thank you.
Thank you.